Hello again. We're going to continue our series on trauma-informed care, and today we have with us Amanda Anderson. Amanda has been on the task force and in hospice and in the military for several years now, working with hospice patients as well as military patients. And so today we're going to look at trauma-informed care for women, uh, looking at women's issues across the board with regards to trauma-informed care. Amanda, thank you so much for being with us today, and the floor is yours.
Thank you so much, Jamie, and thank you everybody for being a part of this and taking the time to see this presentation. This is just a little bit about me and what I've done as far as this topic goes. I do find that of all of my credentials, the thing I'm most proud of is I am the daughter of a Marine Corps veteran myself. Um, and it is part of what drives me to do the work that I do. Um, I always like to make sure that everyone knows that this is not in any way a financial relationship. There are no ineligible companies, there are normal disclosures. Um, because we are examining trauma informed care specifically for women veterans today, I wanted to take a moment and kind of give everybody the opportunity to review trauma informed care. I know you've been watching the series, but just kind of reintroduce a couple of ideas. Talk about the prevalence in our women veterans of both their service in the military and the prevalence of trauma. And then we're going to discuss some specialized care needs and some steps and resources for that specialized care. So, I always like to start with a little bit of understanding that trauma informed care really is about being able to provide solid medical care without re traumatizing patients. It really is about taking a moment or two out of your day just to consider what it is like being on the other side of that fence. And that means actually understanding that your patient has been through something that is life threatening or they considered life threatening for themselves. This is not something that we get to determine our opinion on, much like when we're doing mental health for any other patient. But I always like to also make sure people know that there's a difference between trauma and what we colloquially talk about as drama. We have a lot of family dynamics that come in hospice care and palliative care, and we do discuss this a little bit in this presentation today, especially, for looking at women veterans and possibly those in corrections. Um, so I want to make sure you understand wholly that when we're talking about dynamics, we're talking about things that are maybe external forces, maybe internal, but it's less about those life-threatening, life-altering opportunities. And the areas of concern that we discuss when we're talking about trauma informed care really are a threefold opportunity. It's post traumatic stress disorder, or PTSD, moral injury, and suicidal ideation. Women in the military is not a new concept. Women have been serving pretty much since the inception of the military in some capacity. If you really look backwards, you're going to see women having been medics, having really supported our troops in many ways. But women in combat are a little bit newer of an idea. And so when we look at the service members who are women, it has changed how we look at the prevalence of trauma and their exposures and their individual experiences. So, when we talk about the prevalence of women serving, you're talking about 1.66 million of our service members per the VA in 2021. They're always a couple years behind us. 13%, so that's 1 in 13 of that 1.66 million will report PTSD within their lifetime. The suicide rates for women veterans popped up 30%. 34% in an evaluated 10-year period between 2005 and 2015, which is when we really started seeing the VA initiatives into suicide prevention. Though all veteran suicide rates are starting to show a decline heading into 2020, again, statistics are always a couple years behind. The biggest thing about that is the comparative male rates were only about 13%. And women do struggle with higher rates of military sexual trauma. And we're going to deep dive that a little further. So, when we talk about military sexual trauma, what we're talking about is a very triggering, potentially, opportunity for those of you who could be watching this. So, please make sure you're engaging in self care. But this is about sexual assault, sexual abuse at the hands of someone that they encounter in the military. 1 in 3, 1/3 of that 1.66 million, will tell their VA health provider that they have encountered some form of sexual trauma during their lifetime in the military. That's literally 33%. So, when you're thinking about the prevalence of trauma for this group, this is probably one of the highest reasons that they have PTSD or they have some form of moral injury. Now, because we're looking at statistics, I did want to throw in there that women veterans in corrections, the population we're looking at per the most recent statistics, which is 2021, was about 1,800 women veterans in the correction system. The thing about it is that their crimes are typically related to integration into the civilian system and the transition back to normal life. So when we are looking at caring for women veterans in hospice, hospice and palliative care is a major transition for many people. They have received a terminal illness. And so we really want to focus in on making sure they're receiving good support, making sure that we are really taking care of their mental health as much as we are their physical health through that end of life care transition. So, no presentation about hospice and palliative care would be complete without looking at a few of the common reasons why female veterans could wind up in hospice care. Um, the VA didn't have great statistics on like how much of a difference it is. But heart disease, particularly congestive heart failure, is one of the highest reasons that we see women veterans in hospice and palliative. Diabetes would be your second reason. But cancers, and particularly reproductive cancers, with bone cancer being just a little bit behind that, and lung cancer, are your most common reasons for women veterans to be in a terminal situation. So, as we're going forward and talking about the hospice and palliative care piece, when we are looking at trauma informed care, we want to make sure that we are considering what they've been exposed to, how they've been exposed to it, and how we can keep from re traumatizing or re triggering them during their time in hospice and palliative care, or really in medical care, period. But we are focusing this mostly on their end of life care. So I love this picture of the Women's Memorial for Vietnam. Vietnam veterans are our highest demographic in hospice and palliative currently. And so, in looking at our women veterans with PTSD, we are considering that they have a lot of the same triggers that their male counterparts do if they served in combat. So, pops, bangs, sounds, smells, things that could be combat related. What often doesn't get discussed as much is, as we were talking about with the military sexual trauma, sometimes those smells, sounds, hypervigilance aren't about what they saw in combat. It's about something that happened to them personally. So the smell of a cologne, the smell of popcorn, you never know what it could be. And so we have to really work with our patients independently to see what could be a triggering sight, smell, sound situation for them. And it has to go a little deeper than just assuming, oh, they saw combat. We have to be willing to be open enough to have that conversation with them. Moral injury is actually a higher prevalence situation with military sexual trauma. People would think it would actually be the PTSD, but that's not really the case. And it's because a lot of times sexual trauma victims blame themselves for what happened. So when you're looking at the moral injury triggers that a women service members can have, it starts with people in authority. It starts with, things that remind them that, you know, having children, they have issues with understanding that they still are the person they were before that happened to them. So it's really important to be willing to engage with them and find out what their story is. I love this stop sign, and I've kept this graphic in a few different things because when we talk about consent, we often think about hospice and palliative being a very supportive, touchy situation. We want to be able to hug and hold hands. And with female veterans, we are really having to consider asking about, is it okay to touch me? Is it okay to give that hug? Is it okay? They may not be super touchy people. And this doesn't have to be a difficult conversation. This doesn't have to be something that is long and drawn out. It can be a simple question. And you don't have to use the word consent. You can just say, hey, I see that you're struggling right now. Is it okay if I hold your hand? They're going to appreciate that more than you just reaching out to them. A lot of times, people who have been through sexual trauma have a very heightened startle and very heightened hypervigilance response. And so, someone touching them may set off that trigger. So, another thing I always like to bring forward anytime I'm talking about any population of veterans, and more so with those who have backgrounds in sexual trauma, is the different models that we can use for hospice and palliative patients in trauma informed care. And this is the one that the VA most commonly recommends, which is our stepwise psychosocial model. And so your stage one is usable with any patient, regardless of prognosis, and it's palliating your immediate discomfort and providing social support. And that has a lot of active listening, reassurance, directing assistance, and practical problem solving, working with your providers and loved one to avoid those PTSD triggers, and mediating discussions with providers and loved ones. Stage two is more based on prognosis, as is stage three. So we're not going to talk a whole lot about those today. Um, but because we are dealing specifically with women's issues, we do want to make sure that we're taking those traumas down. So, active listening is about if something does set off a trauma trigger, that you do give them that reassurance. Make sure that you are hearing them, Making sure you're not saying, I understand what you're going through, but really allow them to talk, really allow them to share. It's important that you are actively listening to what they are sharing with you because their experience is unique. It's not the same as their male counterparts. They may have seen combat, but they also may have had something else happen to them that's more traumatizing than what they saw in combat. Don't assume. It's very important to hear their story. Direct assistance in solving practical problems in corrections, because I know that we are discussing this some with our corrections friends as well. Some of this may not apply as much, but it does happen where maybe in common areas, and we see this in hospitals and homes and just general places, where a TV show can cause a trigger, where something that it seems like an innate sound is present and it sets the veteran off. Make sure that you eliminate the trigger first. If they're pointing to the TV, like, maybe there is something on there that is triggering to them, shut the TV off or change the channel and then go to them and ask, what can I do? What else can I do? You've already taken the practical step of changing what you can. Now you have to help kind of de escalate them a little bit. I love the mediation piece because when we talk about providers and loved ones, if we are dealing in even a hospital or a corrections environment, it may be a little less so that you're getting to have some of the tougher conversations that we have in the field with families, but it's still necessary to communicate with the family what's going on. That may mean advocating for your female veteran about giving them an opportunity to discuss what happened. It could be that they're ready to tell their family. It could be, there are a lot of open doors that come with being able to process. And so acting as their advocate is very important when they're in that end of life piece. And working with both the providers and loved ones to avoid triggering PTSD symptoms. Though the practical piece we discussed a few minutes ago, like changing the TV channel, is very important. It's also important to make sure that those working with your female veteran is aware of what that trigger might be. If they did see something that you can then ask, what about that situation was a trigger to you? You want to make sure, again, that you're listening, you're hearing their story, but then you're also working with them to make sure that you know what those triggers are and you help educate those providing care not to make a mistake or approach them in a way that could be triggering to them. Like I said, we do have two other sections of intervention. We're not going to deep dive those here, but I do like to throw them out. When working with veterans, you do have breathing techniques, mindfulness, meditation, aromatherapy, massage, music or art therapy, depending on the prognosis of your patient. Your patient has to be able to participate in these things in order for them to be effective. So you want to make sure that they are still cognitively capable of interacting with you and that they would benefit from such an interaction. I do have some resources here that deep dive some of these things a little more. Um, I make the joke about the fact that you can find mindfulness and meditation apps anywhere, along with some additional um, getting to know trauma informed care as a general. But I really like to make sure when you're working with veterans, regardless of gender, that you know about your VA resources. My personal favorite are the mobile apps because we do have PTSD Coach, which is usable for any of our trauma informed care needs. Um, if you download that app, there are a lot of tools in the tools section that actually will take you through some of those stage 2 pieces and be very helpful for you to use in real time. So, though this is a very sky high overview of what some of the very specific things are that we deal with for women veterans, I want you to know that the trauma informed care piece for them does really come down to many of the considerations that we have regarding their mental health. We want to make sure that we are listening, that we are responding, and that we are giving them the space to share what it is that they need in real time. So be willing to reach out for resources. You are not in this alone. I am including my personal information currently. If you have any pieces, you can email me at amanda.anderson@startcorp.org. My cell phone number is also there. You can also reach out to the VA task force at veterans@lmhpco.org. And there are also a huge amount of references back here that you can check out that not only speaks about the trauma informed care pieces, but you can also find a lot of the statistics in the National Center for PTSD and the VA sites. I appreciate you taking the time to watch this video today, and I hope it really does assist you in being able to better care for your women veterans in your facility.
Thank you, Mandy. I appreciate the insights that you've been able to offer this afternoon to us. And we look forward to continuing to provide this series on informed care, trauma-informed care to the other categories that we are listing. So thank you again, Mandy. I appreciate all your help.